Hey guys, how are you all? So welcome back to MedSteps YouTube channel. Let me confirm my voice is clear or not. Yeah, good. So hello everyone, welcome back to MedSteps YouTube channel. So this is your host Medico Anandjana, final year medical student. So today is our day 3 of our first week general surgery series. So our live topic will be today like fluid and electrolytes balance. It's like very super important topic in your clinical rotation. If you're starting your clinical rotation, this is the main topic. If any patient have hypotension, what are the fluids we have to give? So everything in electrolyte imbalance, what are the things we have to do? Everything like top to bottom, from basic to clinical, everything we are going to discuss after 2 hours. Okay, so this 2 hours for study purpose. After 2 hours, 1 hour we are going to do live discussion. Okay, so as usual, I'm following Pomodoro method. That means now we are going to read, we are going to study total 3 hours. In these 3 hours, we have to divide into 3 seasons. Okay, in first season, we have to divide into two parts. That is 50 minutes will be like for study, 10 minutes will be break. Okay, so like that for 2 seasons we are going to read. Then after one season will be we are going to do live discussion, okay, about fluids and electrolytes and imbalance. Okay, so without time waste, and thanks for joining with me and study with me. So here, if you're practicing for if you're preparing for FMGE or NEET PG, USMLE, or for clinical exams. So this what are the things we are discussing here? Everything it will help in your exams. Okay, so we are going to study together for 3 solid hours. So grab your books, water bottle, and your focus. So let's make this time count and focus and no distractions. Okay, so without time waste, let's start season 1. Okay, So guys, let's take 10 minutes break. Successfully we completed our season 1. Okay, mostly I completed about this fluids and this thing. So after 1 hour we are going to discuss um, about fluids and electrolyte imbalance and everything in live discussion. Okay, so let's take 10 minutes break. So guys, 10 minutes break done. So let's start season 2. Then after we are going to discuss our live discussion. Okay. So 15 minutes, season 2. Without time waste, let's start. And main thing, if you're studying with me, what are the topics you are studying now? You can message me, you can drop me in comment section in chat. So while doing live chat, that time we can discuss the topics also. Okay. Good. So guys, we successfully completed our season 2. Okay. So let's take 10 minutes break. Then after we are going to start our live discussion. Okay. Before going to live discussion, if you have any doubts or any questions, any queries, if you have anything means you can drop one message in comment section and If you're studying with me, just drop one message. So based on that, we will discuss step by step. Okay. So today our topic will be like fluids and electrolytes imbalance. From top to bottom, everything we are going to discuss about this thing. Okay. So let's take 10 minutes break. Then after we will continue. So guys, let's start our live discussion. So today our topic is fluids and electrolyte imbalance. Okay. So before going to live discussion, please let me check my voice is clear and loud or not. Yeah, it's good. So let's start. First of all, before knowing the fluid and electrolyte imbalance, we have to understand about fluid. Okay. For example, if you're seeing, okay, for example, I'm 21 years old. Okay. So I'm 65 kgs of weight. So how much percentage of body, how much percentage of water fluid content in our body, in my body means 40 liters you can see, because total body water will be distribution. Okay. What are the fluids and electrolytes we are seeing means the body water distribution, it will carry 60 percentage of body weight. Okay. For example, if I'm like 65 kgs means 40 like 40 liters of water you can see in my body. Okay. So that's why we have to know this thing, because how much percentage of body water is present in your body. Okay. If you know this thing, based on kg, based on weight, based on body condition, you can give fluids properly. Okay. So that's why we have to know this thing. Now, this total body water content is divided into two types. That means two parts. One is intracellular fluid, another one extracellular fluid. Intracellular, this is like compartments. So that's why first one intracellular fluid. Intracellular fluid means, for example, this is cell. Okay, inside the inside the this inside this cell, you can see, you can tell that is intracellular fluid. So inside the fluid, you can call intracellular fluid. When it's outside the fluid, you can call extracellular fluid. So actually, you have to know, we have to understand one thing: our body is made by many cells, right? So inside this cell, you can see intracellular fluid. Outside this cell, you can see extracellular fluid. So first of all, in intracellular fluid, you can see 2 by 3 percentage of total body weight. How much I told? Total body weight. For example, my body weight is 65 kgs. So in that 65 kg, mostly 60 percentage of body weight will be fluid. Okay. So now I divide into two parts. One is intracellular fluid and extracellular fluid. In intracellular fluid, you can see 2 by 3 percentage of body weight. In extracellular fluid, you can see 1 by 3 percentage of total body weight. So this 40 percentage, 40 liters I told, right? So in intracellular fluid, you can see 28 liters. Okay, that is intracellular fluid. That means inside this cell. Next, extracellular fluid. In extracellular fluid, you can see like 18 liters, 12 liters. Sorry, it's in extracellular fluid. You can see 12 liters of fluid. Okay. Now, this extracellular fluid is divided into two parts. One is interstitial space fluid, another one plasma volume. So in interstitial fluid means what I told, our body is made by many cells, right? Like millions of cells. Like in between the cell, we can see some space. In that space, we call interstitial space. The space is filled by some fluid. That fluid we call interstitial fluid. How much liters you can see? 9 liters. 75% of fluid you can see in interstitial fluid. Okay, next one, plasma water. Plasma water means like intravenous. That means in venously you can see some blood, some fluid that collects like blood and everything will come in plasma water. You can see like 3 liters. That in percentage you can tell like 22%. So this is the distribution of water content in our body. Okay. So next we are going to discuss about key electrolytes by based on compartments. So why we have to know these compartments? If you know this thing based on um, electrolyte imbalance, you can treat very easily. Okay, you will get good idea. So that's why we have to know this key electrolytes by compartments. First, I will tell some electrolytes. Then after we are going to divide into extracellular fluid and intracellular fluid. Based on that percentage, we are going to discuss. Okay. First one, sodium, potassium, calcium, chloride, magnesium, bicarbonate. So first we are going to see the intracellular fluid, means inside the cell. So inside the cell, if you are seeing like sodium and bicarbonate, it will be like very low. Okay, low concentration you can see in inside the cell, means inside the cell means intracellular fluid. You can see sodium will be low and calcium will be low, chloride will be low, and bicarbonate will be low. Okay, so these are the things you can see very low in intracellular fluid. So next we are discussing about extracellular fluid, means outside the cell. Here you can see the sodium will be high, the bicarbonate will be like moderate, the calcium will be high, the chloride will be high. Okay, so the potassium will be low. So these are the things you can see in, and magnesium will be moderate. In extracellular fluid, you can see this type of compartments and values and percentages. Okay, so these are the key electrolytes based on compartments. So next we have to know the various electrolytes, and the electrolyte have parameters and use on some normal ranges. When patient come to you, that time you have to draw some blood in the electrolyte balance. The time you are drawing some blood. Okay, then after you are doing, you send for pathology for investigation. Then they will mention some ranges. Okay, so you have to know the values perfectly. If you don't know the value, so now I'm going to tell that values. Try to remember these things. First one, sodium. In sodium, that normal range will be like 135 to 145. Okay, sodium value will be 135 to 145. Next one, potassium. The potassium value normal range, you can say like 3.5 to 5.0. 3.5 to 5.0. Next one, you can see chloride. The chloride value will be like 98 to 106 millimole per liter. How much? 98 to 106 millimole per liter. That is chloride. Next, calcium. If you are seeing calcium, 9 to 10.5 milligram per deciliter, you can see. How much? Calcium will be 9 to 10.5 milligram per deciliter. Next one, phosphorus. Phosphorus value will be like 3 to 4.5 milligram per deciliter. How much? 3 to 4.5 milligram per deciliter. This is phosphorus. Next we can see like magnesium. Magnesium value will be, normal range will be like 2 to 3 milligram per deciliter. Magnesium will be 2 to 3 milligram per deciliter. Next, pH of blood, 7.35 to 7.45. Okay, this is the pH blood value. Okay, next, bicarbonate. In bicarbonate, you can see 22 to 26 millimole per liter. Why this thing is important? If you know, if you are getting about value of pH and bicarbonate, usually you can interpret the EBG, means arterial blood glucose. glucose value or venous blood gas, you can easily measure. You can easily interpret it. Based on that, you can do treatment also. So that's why this values is very important. So bicarbonate will be like 22 to 26 millimole per liter. Next one osmolality. The osmolality you can see like 285 to 295 osmolarity by kg based on water content. Okay, so these are the things will comes in normal ranges and electrolytes. Okay, so next, how that fluids and electrolytes will get regulation. So now we are going to discuss about regulation of fluid and electrolytes. First, thirst mechanism. If patient have totally dehydration, no fluid, like hypovolemic state, that time that baroreceptors will get activated and it will the thirst mechanism and it will activate the hypothalamus. Then after when the hypothalamus gets stimulated, then after the hypothalamus will release one hormone, that is antidiuretic hormone or vasopressor from posterior pituitary gland. Okay, when the posterior pituitary gland releases antidiuretic hormone or vasopressor, then what will happen in kidneys? You can see water reabsorption. So because of that water reabsorption, that in that condition, you can see that ADH will do water reabsorption, and there you can see juxtaglomerular cells that in kidneys in nephron, near to nephron. The juxtaglomerular cells will release RAS. RAS means renin. That renin RAS mechanism will get activated. Then we can see sodium retention, means sodium reabsorption, and potassium excretion. Okay, so in physiology we have one concept, that is wherever the sodium is going, automatic water also will go. Okay, so here why this thing happened? Because of hypovolemic state. Okay, that means fluid reduced. So when we are doing sodium reabsorption, automatic water content also will increase. Okay, that's why here we are seeing like sodium reabsorption and potassium excretion. Okay, then after we can see in heart, in aorta, we can see in atrium, we can see one hormone will release, that hormone like anti-natriuretic peptide. Okay, or BNP. It will help for doing like, it will do like nitriuresis. Okay, then after kidneys, it will help to chew electrolytes and water. So this is the regulation of fluids and electrolyte imbalance. Okay, so next we are going to discuss about field of based on fluid imbalance. First we are going to discuss about hypovolemia, then after hypervolemia. That means hypovolemia means the fluid decreased, hypervolemia means the fluid increased in our body. Okay, so first, what are the clinical features we can see? That means signs and symptoms we can say in hypovolemic state. Hypovolemic state means water loss or fluid deficit. Okay, so here we can see dry mucus, low jugular venous pressure, then after hypotension, tachycardia, and decreased urine output. These are the symptoms you can see in dehydration patients. Okay, what are the things? Dry mucus, low jugular venous pressure, hypotension. Because of hypotension, you can see tachycardia. Then after decreased urine output. Okay, so next one, hypervolemia. In hypervolemia, you can say like hypervolemia means fluid overload. That fluid is more amount of fluid we can see in our body. That is fluid overload. So in hypervolemia, we can see whenever the fluid is more in our body, what will happen? Edema. Edema means the fluid accumulates in interstitial space. Then it will cause edema. So edema, then after elevated JVP because of overload of fluid overload, jugular venous pressure will elevate. This we can see that some JVP will get distended. Okay. Next, some sound we can see in lungs, that is we call crackles in lungs. Then after weight gain and hypertension. So these are the main signs and symptoms of hypervolemia, okay, or fluid overload. So now causes. What are the things can cause hypovolemia and hypervolemia? First, I'm going to discuss about hypovolemia. This can cause hypovolemia means, first one, extra renal losses. In extrarenal losses, we can see like GI losses like vomiting, diarrhea, and gastric aspiration, like peritonitis, intestinal obstruction, excessive sweating, burns, severe hemorrhage, excessive use of diuretics like osmotic diuresis, okay, and glucosuria, and like renal disease, okay, and chronic renal failure, deficiency of melanocorticoids, and Addison's disease. These are the pathological conditions can cause hypovolemic state. So next one, hypervolemic causes. In hypervolemic causes means fluid overload. That means excess fluid in intravascular or interstitial compartments because of maybe more amount of intake of fluid, or maybe because of decreased excretion, or maybe fluid redistribution. So these are the main causes can lead to hypervolemic state. So causes will be like first one, excessive fluid intake. It's like iatrogenic causes, more fluid infusion, or if without knowing if you're um, infusing the fluid like normal cell NS, RL, then we can see fluid overload. Okay, and it can lead to cerebral perfusion also. Okay, or cerebral edema also. Okay, so this is the main side effect of this fluid overload. Okay, next one, kidney causes. In kidney causes like decreasing excretion of sodium water. Some pathological conditions can cause this thing like acute kidney injury, chronic kidney disease, glomerulonephritis, and nephrotic syndrome. In nephrotic syndrome, we can see like low oncotic pressure and fluid retention. Next, heart conditions like congestive heart failure. In congestive heart failure, we can see like a decreased cardiac output, okay, and increased RAS mechanism and um, fluid reabsorption. So these are the things, fluid retention. These are the things can cause uh, hypervolemic things. Okay, next one, liver conditions. In liver, you can see cirrhosis. Cirrhosis like decreasing albumin because of that increasing portal hypertension, outspacing will the fluid will increase, RAS mechanism will activate, and water retention. Because of these are the things can lead to hypervolemia. Okay. So next one, endocrine causes. In endocrine causes, three conditions can cause hypervolemia. That is first one, Cushing syndrome. In Cushing syndrome, the cortisol will increase. When that cortisol will increase, automatic kidney will do sodium retention. Okay. Next one, hyperaldosteronism. Hyperaldosteronism means that increased aldosterone and sodium water retention also we can see. Next one, SIADH, like water retention due to inappropriate ADH secretion. Okay, next one, medications. Some medications also can cause hypervolemia, like for example, corticosteroids and NSAIDs, means non-steroidal anti-inflammatory drugs. So these are the drugs can cause hypervolemia. Why? Because NSAIDs means decreased prostaglandin, and it can lead to decreased renal perfusion. So that's why when the kidney is not working properly, then it can't the kidney can't excrete the potassium. So because of that, we can see hyper volemic condition. Okay. Next one, like some intravenous mannitol, like if not excreted well, then it can cause. Next one, pregnancy related things like preeclampsia. In preeclampsia, you can see like a hypertension and proteinuria. The protein will go out. So um, this preeclampsia can cause these things. And another one, eclampsia. Eclampsia means you can say hypertension, proteinuria, and seizures. These are the things you can see in pregnancy females. So these are the pregnancy conditions also can cause hypervolemia. Okay. Next one, maybe some like during labor or during surgery also we can see hypervolemic state. Next one, others like post-operative fluid shift and sepsis with capillary leak, aggressive resuscitation, and overcorrection of dehydration. So these are the things. These are the main causes of hypervolemic state. Okay. So now, just now we discussed about fluids. Okay. Now we are going to discuss about electrolyte imbalance. Electrolyte imbalance means we have some electrolytes. These are the electrolytes will help to maintain the body and the circulation fluids and our body condition. Okay, if any imbalance happened with these fluids, it can lead to like several pathological conditions. Okay, so that's why now we are going to discuss about electrolyte imbalance and how we can do management with drugs, with dosage. Okay, everything we are going to discuss now. First one. So in electrolytes, first one we are going to see the sodium imbalance. Sodium imbalance means first we are going to discuss about hypernatremia. In hypernatremia, that's how much value I told. The sodium normal range will be like sodium 135 to 145 millimole per liter, right? So here, first we are going to discuss about hypernatremia. In hypernatremia, the sodium will be like more than physiological types you can see means hypovolemic state, euvolemic state, and hypervolemic state. Okay, so now first we are going to discuss about hypernatremia. In hypernatremia, the sodium will be like greater than 145 millimole per liter, usually due to because of water loss. The symptoms we can see that is thirst, altered mental status, and seizures. How we can do management? We can give um, dextrose or like D5W or 0.45 percentage of normal saline intravenously. If we are giving these things, we can slowly we are correcting the to avoid cerebral edema. Okay, so we are correcting the thing. Okay, so next one hyponatremia. In hyponatremia, we can see like less than 135 millimole per liter. You can see this is the value of hyponatremia. So in hyponatremia, we have some types that is hypovolemia, okay, or euvolemic, or these are the types in so hyponatremia. Okay, the symptoms will be like confusion, seizures, and coma. So that management will be like 3% of normal saline. Okay, in severe cases like sodium will be like less than 120, and we can give some dose that is 100 ml over 10 minutes, like three times you can give in emergency cases. Okay, and we are giving this thing, we are correcting slowly like less than 10 to 12 millimole per day to prevent cerebral pontine myelinolysis. It's because of hyponatremia, this pathological condition the patient will get. So that's why we are preventing this thing like central pontine myelinolysis. Okay, so that's why 3% of normal saline we have to give in severe cases. If you are not giving, if you are not doing management properly, it can lead to the central pontine myelinolysis pathological condition. Okay, so that's why it's very important. Next one, potassium imbalance. In potassium imbalance, you can see first one, hyperkalemia. In hyperkalemia, you can see like potassium levels will be like greater than 5.5 millimole per liter. What I told about normal range, the normal range will be like 3.5 to 5.0 millimole per liter. Okay, so here in hyperkalemia, we have some causes that is like renal failure can cause hyperkalemia, hemolysis, and acidosis. These are the things can cause hyperkalemia. Okay, so here this hyperkalemia and about this potassium, it's very life threatening condition, right? Because you can see some change in heart. Okay, like for example in ECG you can see like U wave and flat. Uh, in ECG, in patient have hyperkalemia, you can see like tall T wave and wide QRS and sine wave you can see. Okay, so these are the ECG pathological conditions, ECG conditions. So what we can do, we have to do emergency management. For that emergency management, first of all, we have to start with calcium gluconate. Then that calcium gluconate, like 10 percentage, we can give, that is 10 ml intravenous over like 10 to 15 minutes you can give. Next one, insulin and dextrose, like 10 units regular insulin with 25 grams of dextrose. Okay, you can 50% of dextrose you can give. Next one, salbutamol medication. Salbutamol nebulization you can give like 10 to 20 milligram. And furosemide for decreasing the speed of intravenous respective to volumic state. Next week, after this everything, you can still if it's not correcting the potassium level much, then we have to do dialysis if refractory. Okay, next one, hypokalemia. Hypokalemia means the potassium less than 3.5 millimole per liter. Causes will be like diuretics, vomiting, and diarrhea. The ECG will be like U wave. In ECG, you can see like U wave and flat P wave. You can see. In management, oral potassium you can give like mild cases. You can give oral potassium like 20 milli 20 milli equals. You can give like PID for 3 times per day. If it's like severe condition, you can give like potassium chloride 10 to 20 um, 10 to 20 milli equal per hour. You can give maximum will be like 40% you can give, but never push intravenously, because if you're giving intravenously potassium chloride, it can lead to arrhythmia. So that's why always we have to give very slowly and like over hour. Okay, based on that dosage, you can give very slowly. Okay, next one, we are going to discuss about calcium imbalance. In calcium imbalance, first one, hypercalcemia. In hypercalcemia means we can see like greater than 10.5 milligram per deciliter. Symptoms will be like if any patient have kidney stones or bone related pathological condition, or maybe some groin regions, or maybe gout. So these are the things can increase calcium level. So in that things we can see hypercalcemia. So in ECG we can see like one sign, that is sharp Q P wave. Okay. So how you can do management means normal saline, hydration 200 to 300 ml per hour, or you can give furosemide or bisphosphonates, for example like zoledronic acid, especially for pregnancy patients. Next one, hypocalcemia means low level of decreasing calcium levels, like calcium will be like less than 8.5 milligram per deciliter. So the signs will be like thoracic and trosilio and tetanic. Example, in ECG you can see like prolonged QT. Okay, and in management we can give intravenously calcium gluconate 1 to 2 grams intravenously over like 10 minutes. And you can see like you can give like vitamin D or oral calcium if chronic cases. Okay, next one, magnesium imbalance. In magnesium imbalance, like in hypermagnesemia, like greater than 2.5 milligram per deciliters at values, then that causes like renal failure and laterogenic things. Okay, the symptoms will be like we can see um, decreasing deep tendon reflex and hypotension or hypotonia and respiratory depression. So uh, these are the main clinical sign and symptoms we can see in hypo hypermagnesemia. Because why I know this thing, this much properly means when I'm doing obstetric gynecology department, that time one patient have like this severe preeclampsia with systemic features. Okay, so for that patient we gave magnesium. After magnesium, the patient getting respiratory depression and hypotension, okay, and hypotonia. Okay, that time the doctor told just to go and check deep tendon reflex. I checked, the deep tendon reflex decreased. So then I realized this, whenever you are giving magnesium, always you have to check deep tendon reflex, because it can lead that, because of this hypermagnesium can lead to respiratory depression, and then after it can lead to death also. So that's why this is very important. Okay, so in hypermagnesemia or magnesium toxicity, we can give calcium gluconate. Okay, so this is the main important points for our USMLE or some exams. Okay, so we can give intravenous calcium gluconate and diuretics and dialysis if severe cases. Next one, phosphate imbalance. In phosphate imbalance, first we are going to discuss about hyperphosphatemia. In hyperphosphatemia, when you can see this condition, when it's most common in chronic kidney disease. Okay, in chronic kidney disease, and you can see like for treatment you can give intravenous. For treatment you can give like phosphate blinders like cevilamide or calcium acetate. Okay, actually this is new drug, that's why I'm not getting that much properly that pronunciation. Next one, hypophosphatemia. If any patient have hypophosphatemia, you can see that hypophosphatemia, then you can see like refeeding syndrome, okay, or alcoholic patients, you can see hypophosphatemia. Okay, so symptoms will be like weakness and rhabdomyolysis. The treatment will be like oral phosphate, intravenous, or potassium phosphate. So this is the management of electrolyte phosphate imbalance and electrolyte imbalance. So now, how you can select the fluids, because we have Ringer's lactate, normal saline, dextrose, albumin, colloids, electrolytes. These are the things, many things we have. So how we can select based on pathological conditions means, first, first I will tell about fluid. Then after composition, what are the things present in that fluid? Then after how we for what pathological condition, indications, we will uses we are going to discuss. Okay. First one, normal saline. In normal saline, like 0.9 percentage of normal saline, we can see composition, that is sodium will be, sodium will be like 154, chloride will be like 144 percentage, we can see. Okay, that is the composition. When we can use this normal saline means, like if any patient have hyponatremia, hypotension, and shock. For these three conditions, we can use normal saline. Next one, RL, are also known as Hartmann's or Ringer's lactate. In composition, we can see like sodium, chloride, potassium, calcium, lactate. These are the things you can see in Ringer's lactate. Okay, so when you can use this Ringer's lactate means if any patient got like burns or trauma, so that in the trauma patients and burns patient, you can use Ringer's lactate. Okay. Next one, dextrose, dextrose 5, and water. Okay, like free water plus dextrose 5% of dextrose and water content. Like in composition, free water and 5% of dextrose, we can see the, to whom we have to use this dextrose 5 water means like hyponatremic patient and for maintenance. Okay, next one, 0.45 percentage of normal saline. Like composition will be like half normal saline. Like for slow rehydration therapy, we can use for dehydration patient. Okay, slowly we can rehydrate with 45 percentage, 0.45 percentage of normal saline. Next one, 3 percentage of normal saline. It's like very more sodium. We can use for hypotonic saline. For example, for users like severe hyponatremia patient, we can use 3 percentage of normal saline. Next one, colloids. Colloids means albumin. Albumin, like in composition, we can see protein based. That uses will be like if any patient have liver disease or like severe jaundice, in that patients we can see more amount of albumin is going out. Okay, so for that patient we can use this colloids, like volume expansion in hypoalbuminic patient, we can use this type this albumin. Okay, so these are the fluids overview. So how we can maintain this fluid means, we have one formula, that is Hadger formula or 4-to-1 rule. The 4-to-1 rule means based on kgs we can give. The normal maintenance of fluid requirement will be like 25 to 30 ml per kg per day. Okay, so or you can use for children, you can use one formula, that is 4-to-1 rule formula or Hadger rule. So or holiday sagar rule. Okay, here what will happen, if any baby or child 10 kgs, then we can use 4 ml per kg per hour. If any child like more than 10 kgs, then we can use 2 ml per kg per hour. If like more than 20 kgs, then we can use 1 ml per kg per hour. So this is the holiday sagar formula. Okay, based on this formula we are treating here in hospitals. So that's why this formula is very important for your clinical rotation in exams in this case. Okay, so try to learn this formula. Okay, so these are the things about the fluids and the electrolyte imbalance and everything. So in today's section we studied for 2 hours. Okay, then after now we discussed about fluid and electrolyte imbalance. Okay, if you have any doubts, you can ask me in comment section. Okay, and thank you so much for staying with me. And if we have to discuss any topic, so you can comment in comment section. Based on that, I will prepare myself and I will discuss the topic with you. Okay, so if this live is very helping you, it's useful for you, like, share, and subscribe. Don't forget to like the stream because whenever I'm giving live, you will get notification. So based on that, we will study together. Okay. So this is the main things. We are doing this 3 weeks general surgery topics. Why? Because after 3 weeks, in these 3 weeks, we can easily complete our general surgery. Okay. So based on that, after 3 weeks, we are going to start with like internal medicine, some other topics. So day now we are in week 1, day 3. So today our topic is fluid and electrolyte imbalance. If you this is your first time you are visiting this channel, means we already completed our day 2 like short. The day 1 will be like wound healing and asepsis and everything we discussed. Okay, so these are the topics. So tomorrow we are going to discuss another new topic. You will get notification. Try to stay with me for 3 hours and same to same. Always every day we will discuss on the same time, same live, same platform. Okay, so let's take care and thanks to stay with me. Have a good day. Take care. Bye bye. So I'm ending that live section, live season.